Hi, this is Dr. Bhargava, and this video is about findings on CT studies negative for acute pulmonary embolism. So, CT-PE protocol is a very commonly performed CT, especially in patients who are suspected of having an acute pulmonary embolism from the ER or on inpatients. This is because the signs and symptoms of PE are non-specific, and a CT angiography of the pulmonary artery provides definitive answer for the diagnosis of acute pulmonary embolism with filling defect seen in pulmonary artery branches to diagnose PE. D-dimer is very sensitive but non-specific. At the same time, about 90 to 95% of the CTs performed for PE are negative for PE. But the patients still have PE-like signs and symptoms such as chest pain, shortness of breath. AIDoc is a very useful tool. If your institution has not subscribed to AIDoc, I strongly recommend that you look into it. AIDoc is the name of a company, and one of their modules is for CT-PE studies, where with more than 95% certainty, it can rule in or rule out pulmonary embolism in these CTs. The algorithm looks for filling defects in pulmonary artery branches, and it is so good that most of the times I do not pay much attention to the pulmonary artery branches to look for or to rule out acute pulmonary embolism. So, since 90 to 95% of these studies are negative for PE, and AIDoc can very easily rule out PE, the studies are challenging because patients still have, like I said, signs and symptoms that are suggestive of acute pulmonary embolism, although you have ruled out PE, which is a life-threatening abnormality. So what other abnormalities can be seen in these patients that can present with PE-like signs and symptoms? So these findings can be either in the lungs, pleura, chest wall, bones, heart, or the vessels. And this video is about such findings, or it's like a review of what else can happen in these patients where CT has been performed to look for PE, but it's negative for PE. So let's start with a example of acute pulmonary embolism, a positive study where this is a filling defect in one of the right lower lobe pulmonary artery branches, also seen here on the coronal projection, and there are some findings in the lung windows in the supplied portion of the lung showing developing pulmonary infarct. This patient also has right heart strain. We see that the width of the right ventricle is more than the width of the left ventricle. So this study is positive for PE, developing infarct in the right lower lobe, and right heart strain. This is what we look for in a positive study. And if you have AIDoc, then immediately the software program will flag the study and it will show you where the filling defects are identified in the pulmonary artery branches, making your job much easier. This is a companion case, and this case shows findings that are suggestive or consistent with septic pulmonary embolism. In those patients, we don't see typically filling defects in pulmonary artery branches, but since the infective emboli go through the pulmonary artery branches into the lungs, we see findings suggestive of lung infection. So there are multiple bilateral cavitary lung nodules, and there are bilateral reactive small pleural effusions. And those findings are also seen on these two coronal images. So remember, septic embolism. This is our next patient, and this is important because the images on these patients show common findings in a particular demographic, which is more commonly negative for CT-PE studies. And these are young females who are obese, present with respiratory symptoms and get a CT scan through the ER. In these patients, most of the times the CT is negative for PE, and also the CT is negative for other findings that I will show you later in this video. And here you have to look for findings that are suggestive of obesity hypoventilation syndrome. That is the diagnosis in these patients, but this diagnosis is not made on imaging. But there are imaging findings that are supportive of this diagnosis, such as low lung volumes, bibasilar atelectasis, obese body habitus, signs of pulmonary hypertension, and collapsing large airways. And so those cluster of findings should suggest to you that in this demographic, older females, young females with negative CTPE study, the diagnosis is obesity hypoventilation syndrome. All right, so now moving on to what all can we see in these patients. The most common findings seen when the study is negative for PE is heart failure. And so here we see in lung windows interstitial pulmonary edema on the axial and coronal images. We see dilated left ventricle, and we see bilateral small pleural effusions. Putting everything together, they have congestive cardiac failure. This is our next patient where we see similar findings of interstitial pulmonary edema. And instead of the dilated ventricle, here we have thick septum. And so this patient is in failure from hypertrophic cardiomyopathy. This is our next patient where their chest pain was later attributed to coronary artery disease. And these are some axial images. And this one is blown up because this best shows the narrowing that is seen in the mid LAD. We have a plaque that causes narrowing of the LAD, and this plaque is calcified and non-calcified. So remember, these patients can present with chest pain from coronary artery disease or angina. Here's our next patient, and they have pulmonary edema, but it's from fluid overload because they have missed their dialysis. And I say that because on their chest x-ray, we see a dialysis catheter, we see enlarged cardiac silhouette, we see perihilar vascular congestion, dilated cardiac chambers, and pulmonary edema is also seen here on the coronal images. So when patients with end-stage renal disease are on dialysis and they miss their dialysis, they develop pulmonary edema, and they may have CHF-like symptoms that brings them to the ER, and a CTPE study may be performed, and you may find that there is no evidence of PE, but findings suggestive of pulmonary edema. Here's our next patient. The next category of findings seen on these studies is from infection. And here, pay attention to the airways. In the right lung compared to the left lung, there is mural thickening, also seen here and also seen right here. This is from bronchitis. There may be some filling defects from secretions inside the airways also. So infection also can present with PE-like signs and symptoms. This is another patient where we see developing infiltrates from bronchopneumonia. This patient has large focus of consolidation, seen right here in the right upper lung, consistent with pneumonia. This patient has pneumonia, seen as a large focus of consolidation, with destruction of the lung parenchyma seen in these foci, suggestive of a more severe form of pneumonia called necrotizing pneumonia. They also have bilateral severe COPD. This next patient is an elderly female, and she has findings mainly in the middle lobes, suggestive of infection. There is mural thickening of small airways, consolidation, and these findings suggest Lady Windermere syndrome. This is a common boards question. This is our next patient, and we find a loculated pleural effusion with peripheral pleural calcifications. Here is our next patient. Their CT was negative for PE, but they have pneumomediastinum, probably related to their prior tracheostomy, and also have a small right-sided pleural effusion. This next patient has a loculated effusion with pleural thickening and enhancement, and so you want to raise a suspicion of superimposed infection or empyema. This patient has a focus of air, suggesting infection from a gas-producing organism, so again, suggestive of empyema. This is our next patient. So now the next category is emphysema and interstitial lung disease that can present with PE-like signs and symptoms, and patients can get a CTPE study. And so this patient has severe emphysematous changes in both lungs, also seen here on this coronal projection, and we see enlarged pulmonary artery suggestive of pulmonary hypertension. This is our next patient showing reticulation, which is severe in bilateral lower lobes, consistent with usual interstitial pneumonitis or a form of interstitial pneumonia. This next patient, we see extensive emphysematous changes in both lungs, and the new finding compared to the prior study was a vertebral compression deformity. Now we move to another category where patients present with PE-like signs and symptoms. The CT is negative for PE, but it shows signs of a cancer, a primary lung cancer, a metastatic lung cancer, or metastatic disease from another primary to the lungs. So here we see this mass in the left lung in a patient who was diagnosed with lung cancer. This is another patient where we see lung cancer with associated signs of asbestosis. We see pleural calcifications seen in both lungs, along with a small effusion on the left side. This next patient also has a cancer which is invading the posterior chest wall, seen right there in the right upper lobe of the lung. This patient has extensive cancer, seen best on this coronal image. There is lymphadenopathy, pleural effusion, and encasement of the brachiocephalic vein. SVC is seen right here, and so the branches of the pulmonary artery are encased and narrowed. And so those are the things we pay attention to when there is a cancer and it surrounds the vascular structures. We want to talk about encasement, abutment, narrowing, occlusion, those kinds of things. This is our next patient where we again see a large anterior mediastinal mass, turned out to be cancerous. This patient has metastatic disease, not just in both lobes or in both lungs, but also in the liver. So pay attention to the edge of the field of view, the lower neck, the supraclavicular region, and also the part of the abdomen that is included in that CT's field of view. This patient has extensive cannonball-like metastatic disease in both lungs. This was from a sarcoma. This next patient had prior surgery, so we see post-surgical changes, foci of air fluid level, and fluid that is seen in the upper aspect of the right lung. So remember, post-surgical changes can also present with PE-like signs and symptoms. This patient developed a hematoma in the anterior mediastinum. They've had prior sternotomy. We see changes of that here. And so with hematoma, we want to look for any signs of contrast extravasation that suggests active bleeding at the time of imaging. This next patient has a large hiatal hernia that was causing PE-like signs and symptoms, best seen on this coronal image. So these patients can have distension and mass effect from this hernia. It is most part of the stomach that is sitting in the chest instead of in the upper abdomen. We can also see in these patients signs of aspiration and reactive pleural effusions. This is our next patient. Their finding was in the edge of the field of view, seen right here as a large hypodensity in the peripheral aspect of the spleen from a subcapsular hematoma. We see some hyperdensity, which is blood right here. And so typically in this phase, when the CTPE study is acquired, the abdominal organs that are in the field of view do not show much enhancement because it's in the arterial phase or early arterial phase. And so we see spleen in this fashion, and we ask for a CT of the abdomen and pelvis in the portal venous phase. And now we see enhancement of the spleen and this large subcapsular hematoma. There is some blood here, but there is no contrast extravasation or active bleeding. This is our next patient, and here we performed a CTPE study. The CT was negative for PE, and we found insufficiency fractures, which are seen right here, and also a healing fracture there and right here. And so look at the bones, because sometimes patients may present with chest pain, and even without trauma, especially in older patients, they may have insufficiency fractures. And so I see this with the trainees, that if there is no history of trauma, then they don't evaluate the bones very carefully. So don't do that. Look at bones in all the patients. Here again, the cause of this patient's chest pain on this CTPE protocol was multiple rib fractures. This is our next patient. Their etiology of chest pain was in the breast. They've had a procedure. They had a procedure, and after the procedure, they are developing an abscess, and that was causing their chest pain. This is our next patient, and here the interesting finding is that their gastric lap band was too tight, because of which there was obstruction, and food material that they were ingesting would not go through the gastric lap band into the stomach. And so there is stasis of ingested food in the esophagus, and that was causing their chest pain and shortness of breath. In these patients, there can also be signs of aspiration. Here's our next patient. They had a abdominal laparoscopic surgery, and after surgery they developed extensive emphysematous changes involving the chest wall, and they presented to the ER, and a CTPE study was performed. And so in this lung window, which is very useful for looking at pneumomediastinum or chest wall emphysema, we find extensive chest wall emphysema from prior abdominal surgery. This is our next patient. They had a tummy tuck procedure where subcutaneous fat was removed. We see some scarring, and we see a focus of air here, a focus of air here. And so frequently after surgery, they may present with abdominal pain or chest pain, and a CTPE study may be performed. And the utility of this study is to, one, rule out PE, which AI Doc does very efficiently. Two, in a post-surgical setting, look for any a fluid collection such as seroma, hematoma, or abscess formation, which we did not find in this patient. This is our next patient, and we used to see these findings during the epidemic a few years ago, the COVID-19 epidemic, but not anymore, where peripherally in both lung fields we find ground glass or infiltrative opacities, right? And this is classic for COVID-19 pneumonia. Here is another patient where they were diagnosed with COVID-19 infection. We see characteristic findings on their CT-PE protocol, and we find these ground glass peripheral opacities in both lungs. This is another patient where they had COVID-19 but also had acute pulmonary embolism. So we see these filling defects in right lower pulmonary artery branches. We know now that COVID-19 predisposed to a coagulopathy, and these patients were at risk for developing thrombosis in the arteries and veins and at risk for acute pulmonary embolism. This is our next patient. They were found to have this focus in the liver on their CT-PE study, and a CT abdomen and pelvis was performed for further evaluation. And we see here there is hypodensity with peripheral thick wall enhancement consistent with abscess formation. Here's our next patient, and the CT was negative for PE. It showed this large hypodensity in the right lobe of the liver, for which a dedicated CT abdomen and pelvis was performed, and a follow-up MRI which showed this very large tumor arising from the adrenal and involving the liver. This turned out to be adrenocortical carcinoma. This is our next patient where the finding is in the kidney, and they have a renal cell carcinoma that has grown through the renal vein into the IVC, and we see that finding over here. Also, the IVC is expanded. And so pay attention to abdominal organs. They may have a pathology which may lead to PE-like signs and symptoms, and patient may present with that and get a CT-PE study from the ER. Thank you for watching.